Thank you everyone for joining us for medical rounds. Before I begin with the introduction of our speaker today, I just want to proceed with the land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. So today we will have Dr. Lorne Schweitzer give what I anticipate will be a riveting talk in the field of infectious diseases, like as it's not even possible to be more riveting than infectious diseases, but Lauren will talk to you something even more riveting. For those of you who may not know him, Lorne Schweitzer obtained his medical degree from the Université de Montréal in 2015, followed by residency training in internal medicine and an outstanding fellowship training in infectious diseases and medical microbiology at McGill University. And some of you know that he is, he was a star as a fellow, acting as a junior, if not sometimes senior faculty member in terms of his knowledge. He pursued additional research training in immunology and in antiviral cell therapy with Dr. Jean-Sébastien Delisle at Hôpital Maisonneuve Rosemont. And he's currently completing a combined Transplant-Oncology Infectious Diseases Fellowship at Columbia University in New York City. Thank you very much, Lauren.
Thank you very much, Don. It's hard to beat your introductions, and I appreciate all the kind things you had to say. So today I'm going to be talking, it's a bit of an aspirational talk, really, about the next generation of antiviral therapies and where I think things are really going in terms of antiviral therapies for particularly transplant immunocompromised individuals, which is, as Don mentioned, my area of clinical interest. So in terms of the objectives for today's talk, I will describe briefly the challenges associated with viral infections in transplant recipients. I'll talk a bit about the current landscape of virus-specific T-cell therapies, which is what I've worked in quite a bit for the last few years, and then project some possible applications for gene therapies in treating viral infections further down the line. I have no relevant financial disclosures. I do receive salary support from the FRQS and the Royal College from a Detweiler traveling fellowship. So talk a bit about the challenges associated with viral infections in transplant recipients. One of the main issues that we deal with as infectious diseases physicians, particularly transplant infectious disease physicians, that latent viral infections persist for life. Once you catch HSV or varicella zoster virus or CMV or Epstein-Barr virus, just to mention the herpes viruses, and there's a diverse number of viruses, these viruses are able either to integrate themselves into our genome or they remain as episomes, which is a small mini chromosome that remains in our nucleus, and they persist latently, but with the ability to reactivate and cause clinical disease. We know this very well. Anybody who's ever had a cold sore or shingles has experienced reactivation of a latent herpes virus, and this can happen decades after the initial infection. So one of the big problems we have in transplantation, particularly in solid organ, but as well certainly in hematopoietic stem cell transplantation, is that latent viruses can hitchhike with transplanted tissues. So recent publication in Frontiers in Immunology looked at a large, almost 160,000 person United States American registry and of renal transplant donor recipient dyads. And essentially, every transplant ID consult we ever do, one of the first things we mention is what we call the DR status, or donor recipient status. And essentially what we're saying is, does the donor tissue that was put into the patient have or not have a latent infection that could reactivate, such as CMV? And is the recipient already seen that virus, or is this going to be the first time in their life that they're seeing that virus? And interestingly enough, it was found in over 30,000 donor, what we call donor plus recipient negative, meaning kidneys with CMV that we put into a patient that's never seen CMV in their life. These patients, after 1 year, had a 29% increase in their relative risk of mortality and a 17% increase in their relative risk of graft loss. And this is despite modern monitoring for CMV, prophylaxis with anti-CMV agents, and early preemptive therapy when patients develop CMV disease. So we know essentially that when we transplant an organ in a donor-recipient mismatch scenario with these highest risk scenarios, that it's bad for you. You die more, you lose the graft more. And unfortunately, our current strategies for preventing disease don't seem to change that very much. So CMV has been referred to as the transplant troll. This is a bit of a too cute of a troll, really, to refer to CMV. But I would say that as transplant ID physicians, CMV of the viruses is one of the biggest problems we deal with. So we look at CMV. Why do we have such issues? I think that this is representative of many viruses that we deal with, but particularly salient in CMV is that patients tend to develop toxicity to the currently available antivirals, and also the virus can become resistant during treatment. We know that resistance occurs in about 10% of transplant patients with CMV infection. They're very challenging to treat. You can spend an entire lifetime just writing about and thinking about how to treat resistant CMV. Ganciclovir and valganciclovir, our first-line agent, has toxicities, the main toxicity of leukopenia. And particularly in stem cell transplant recipients, we can't use primary prophylaxis with valganciclovir because it delays engraftment and increases mortality due to bacterial infections. And the second-line agents that we use, such as foscarnet and cidofovir, have significant nephrotoxicity amongst other toxicities, which really limits their use. So we thought that the solution to this was going to be new antivirals, and two newer antivirals came out to the market rather recently for prevention and treatment of CMV. The first one is called letermovir. It's only used for prevention. It cannot be used for treatment because of the low barrier to resistance, and it targets what's called the CMV terminase. So has a novel mechanism of action. It's used in hematopoietic stem cell transplantation quite widely. Unfortunately, it's not currently reimbursed by the Quebec government for the primary prophylaxis due to cost. And recent data has emerged that we can use it in solid organ transplantation for patients that are unable to tolerate first-line valganciclovir due to leukopenia. The second drug that's come out is called maribavir, which is an agent that can only be given orally. So there's absorption problems that can be challenging. It's quite resistant. That's quite expensive. And unfortunately, when dealing with patients with resistance to ganciclovir in the registration study, which I show here, only 50% of patients actually achieved viral suppression on maribavir. So half of our patients with resistant refractory disease failed maribavir and needed more toxic agents. And so it turns out, we thought new antivirals would be the solution, but really it's not so fast because, as I mentioned, both have a low barrier to resistance, both are very expensive, and particularly primary prophylaxis, letermovir, as well as valganciclovir, really delay rather than eliminate viral reactivation because that latent virus is still there, essentially kicking the proverbial can down the road. And as I mentioned, maribavir doesn't end up working for about half of our patients. So clearly, we're not doing a great job with resistant refractory CMV. Another herpes virus that we deal with quite a bit in our transplant patients, again, both solid and stem cell transplant recipients, is Epstein-Barr virus, which causes post-transplant lymphoproliferative disorder. So that is an aggressive B-cell lymphoma caused by immortalization of mostly B cells. Can happen in T cells and NK cells rarely as well. And what's important here is that it's not actually caused by active viral replication, which is how most viruses, including the herpes viruses, cause problems when they reactivate. Rather, it's actually a latency program. It's an accelerated proliferation of B cells caused by latency proteins expressed by EBV, even while it's not making copies of itself. So if it's not making copies of itself, and our antiviral agents work by preventing viruses from making copies of themselves, well, antiviral agents are just not going to work for this condition. And indeed, they don't. And finally, related class of viruses we also have quite a bit of issues with in transplant are the polyoma viruses, mostly BK virus, which causes nephropathy and graft loss in renal transplant recipients, and hemorrhagic cystitis in stem cell transplant recipients, but also JC virus, which causes the neurodegenerative disease, progressive multifocal leukoencephalopathy, or PML, which is almost universally fatal in the absence of immediate immune reconstitution. And the reason why we don't have targets for the polyoma viruses for antivirals is that they're very simple viruses, very small genomes, as you see on the left. But most importantly, what they do is instead of using their own proteins to make copies of themselves, they actually push our cells into the cell cycle and hijack our own mammalian DNA replication proteins to make their own copies of themselves to make new virus. Well, that's obviously a problem if you want to target the replication because I think it's quite obvious that if you target mammalian DNA replication, you're going to run into a lot of serious side effects that are going to make such a small molecule agent essentially unusable. And so essentially our current approach, and these are just three examples of viruses that cause major problems, is to give antivirals when they happen to exist. And as I mentioned, for 2 out of 3 of the viruses I mentioned, we don't have antivirals that work against these diseases, and we hope for immune reconstitution. But of course, that doesn't always happen. Patients develop rejection, stem cell transplant patients develop delayed engraftment or GVHD, and so patients remain immunocompromised and often have suboptimal reconstitution of virus-specific immunity. So this doesn't address that underlying pathophysiology of opportunistic infections, which is that lack of virus-specific immunity, but also because these are latent infections that I mentioned persist for life within our tissues, that does not clear the infection. It's not like a bacterial infection where we give antibiotics for some duration and we can eliminate the bacteria from our body. And so we clearly need a paradigm shift in how we approach these infections. So the first technology I'd like to discuss are virus-specific T cells, which solve the first problem of restoring virus-specific immunity. So essentially, the idea is to take either autologous, which has been done, or donor peripheral blood mononuclear cells, which is basically the white blood cell component of a blood donation, and either pull out through techniques that perform what are called cell selection, cells that happen to be present within the PBMCs that already recognize the virus that we're trying to treat, or perform what we call ex vivo expansion, meaning to take cells outside of the body, put it into a bioreactor, and expose these cells to the antigens of the virus that we want to treat in order to expand many-fold the T cells that will recognize the virus that we're trying to treat, and then infuse these products back into the patient to rapidly restore virus-specific T cell immunity. So if we look a bit more closely at a rapid expansion protocol, which I think is the most promising technology and the one that I've been using for the last few years, essentially what we do is we need a seropositive donor. And this is one of the key downsides is we need a donor who's already been exposed to the virus. We expose their T cells either to antigen presenting cells. So they must be the patient's own antigen presenting cells. So we separate those out and load those with peptide libraries. Basically, they're overlapping 15-mer peptides that contain epitopes of the virus that we're looking to treat. Or we can actually, for Epstein-Barr virus, infect the patient's own B cells with Epstein-Barr virus, making immortalized B cells in vitro, just like happens with PTLD in vivo. We mix those all together in a bioreactor called a GREX, which stands for gas permeable rapid expansion. We add a bunch of cytokines to make those T cells expand. And after about 12 to 14 days, we have a product that we can infuse to the patient. We can't infuse it that quickly because we have to do some quality control on it, of course. And this must be done in what's called GMP or good manufacturing practices conditions, meaning we need special reagents, we need trained personnel, and we need the equipment to be able to produce these cleanly so that we are not giving contaminated products to patients. That, of course, is key. So the advantages of rapid VST expansion are that they're what we call MHC agnostic, meaning anybody with any HLA type, this technique can be applied to them, which is not always true of all VST production techniques. It's adaptable because you can change out those peptide mixes for different antigens or even antigens from other viruses or other non-viral microorganisms, in fact. And there's relatively rapid production. It's not overnight, but 12 to 14 days in the scale of producing a T-cell product is quite rapid. But one of the key challenges that I mentioned already is we really need a suitable seropositive donor, and that can be difficult to identify. We need those GMP conditions, so it's quite expensive. There's a lot of administrative complexity in order to ensure that we're producing cells in a safe and clean way. And it takes time to identify a donor and produce the product. And for very sick patients with resistant refractory viral infections, that's just time they often don't have. So one of the solutions that's been proposed are what are called off-the-shelf products. It's nice to call it off the shelf, but of course, we're not taking it off the shelf. We are taking it out of liquid nitrogen, as you see on the right. And essentially, these are third-party, partially HLA-matched donors. And this is a key thing that I will come back to. It has to be understood that these are not going to be fully, in most cases, fully matched to the patient, there's going to be some mismatches when you take cells that have already been produced out of a donor bank. These are cells that are already known to be highly reactive against targeted viruses, which sometimes when we choose a donor, we don't know how reactive their product is going to be. There is a lot of inter-individual variability. They're produced in established commercial manufacturing facilities. So when it comes to accessibility to patients, you don't need to have in-house production capacity. You can have them produced outside, off-site, and have it shipped to you. And there's no production delays because the cells have already been produced. And so one product that's an off-the-shelf product that I'd really like to talk about is called Ebvallo or tabelecleucel. This is an off-the-shelf product targeting EBV positive PTLD. It's produced using those immortalized B cells I mentioned. So you infect B cells with EBV, what we call lymphoblastoid cell lines or LCLs. And very recently in Lancet Oncology, they published the results of their phase 3 registration study that they're submitting to get approved. And there's an objective response rate for very bad lymphomas. These are patients who've already been pre-treated with rituximab and chemotherapy and have failed those treatments. These are patients with really abysmal outcomes and very and few treatment options for the most part. And 50% of patients responded. Of course, it's not perfect. We would hope for closer to 100% as much as possible. But in this kind of a pre-treated population, 50% objective response rate is quite remarkable. And interestingly, if you look at the right at the Kaplan-Meier curve from the study, for patients who did respond, they had a 1-year survival rate of about 85% versus 35% for non-responders, which is essentially probably what would have happened if we didn't treat these patients. So unfortunately, only a subset respond, but the patients who do respond actually did quite well. This has already been approved for commercial use in Europe, and an FDA submission is imminent. It will likely also eventually be submitted to Health Canada. And so I think that this is the first commercial virus-specific T-cell product that anybody in this audience is likely to see or work with. The other off-the-shelf product I'd like to discuss a little bit is from a company called Allovir, which comes out of the Baylor College of Medicine, where they did a lot of the work, of the pioneering work on these rapid expansion protocols. And it's called posoleucel or Viralim M. And essentially, this was a off-the-shelf product with reactivity against CMV, Epstein-Barr virus, adenovirus, which is a respiratory virus which can cause disseminated disease and a lot of problems in immunocompromised patients, human herpes virus, and both BK and JC polyoma virus. And as they show at the bottom, essentially the idea of this product was, and this is mostly done in hematopoietic stem cell transplant recipients, the idea is that when patients are at that highest risk, day 30 to day 100 post hematopoietic stem cell transplant, when their T cells are the lowest and they're at the highest risk of viral reactivations, to try to give them back that virus-specific immunity to either prevent or treat those viral reactivations while we're waiting for their stem cell transplant to engraft. They had four phase 3 trials going. This was a bit of an older figure, so I apologize for the inaccuracy. The prevention study was also in phase 3. And they were all in stem cell transplant recipients, and they were treating 4 conditions: hemorrhagic cystitis, which can be caused by BK or adenovirus in stem cell transplant recipients, CMV, disseminated adenovirus, and for multivirus prevention. They also have a phase 2 trial that's completed for BK virus, for which we're awaiting the publication, but preliminary results were quite promising. And then they had a lot of other ideas in their pipeline. Unfortunately, in December 2023, the company announced that they had suspended all of their phase 3 trials. They've now laid off 95% of their employees, and it looks like the company is basically dead. The reason for that was that their data safety and monitoring board performed a futility analysis and found that it was statistically almost impossible that they would meet their primary outcomes for any of these phase 3 trials. So why did they fail? It's a vital question to move forward with virus-specific T cells, particularly off the shelf. And unfortunately, because there's no publication, we only have press releases, we don't really know. If we can hypothesize a bit, though, one of the things that has been proposed is poor HLA matching. They were quite lenient in the degree of HLA matching that they would allow for a product to be released. The worse the HLA matching, the less likely it is that a virus is going to be recognized by the T cell, because it doesn't have that compatible major histocompatibility complex on the infected cell that it can interact with. And also, you're going to have less persistence, most likely, because of alloreactivity. It may have been that they have poor cellular persistence. There may have been a dosing issue because of persistence. And perhaps it was an epidemiological problem. Perhaps the way they designed their trials was that their primary outcomes were overambitious. Again, we don't have the answers to this. These are only hypotheses until we actually get the data. And so I'd like to mention a bit some of the trials I'm currently working on at Columbia before I move on to talk a bit about where I think this is going in the future. So right now, the trial that is active that I'm working on is called RMDS T cells, or rapidly generated multivirus specific T cells for treatment of viral infections. The PI is my research supervisor, Dr. Pavel Moransky. It's a phase 1 dose escalation study of this T cell product. We target CMV, EBV, adenovirus, and PK virus. We can enroll both solid organ and hematopoietic stem cell transplant recipients in our dose escalation. Unfortunately, we've had slow accrual of stem cell transplant recipients. We've only enrolled solid organ, but we're almost done enrolling. We have 5 products been administered solid organ transplants. We only need to administer 1 more at this dose level, and we will be completing the solid organ transplant arm. 4 patients have completed their safety monitoring without any adverse effects. These are very well tolerated cells. And we've had 2 partial responses and 2 stable disease. So I'm hoping to have a bit more data in about a year's time when we've completed follow-up of these patients to be able to tell you what really happened in the end in their solid organ transplant arm. But it's actually looked quite promising for the moment. We also have 2 upcoming trials that I'm currently working on, a pediatric RMDST phase 1 trial, which the FDA did ask us to separate from the adult trial. We've written it and we are submitting imminently to the FDA. And we're currently finishing writing a pilot study of both BK and JC polyomavirus target cells to treat nephropathy, hemorrhagic cystitis, and PML. And I believe our colleague, Dr. Kiran Thakur, who will be the PI for the PML arm, is on the call right now. So an acknowledgement there. So what's different about our product? Why are we moving forward with this, despite the fact that there's been failure of the biggest trials of posoleucel? So what we think is different about our product, which makes our product advantageous, is the degree of HLA matching, because we are using related donors. And particularly, we're using what we call haploidentical donors. So to explain briefly, essentially, the HLA, or human leukocyte antigen, also known as MHC, or major histocompatibility complex, is the most polymorphic gene in the human genome. However, luckily, all of these genes are carried on the same short arm of chromosome 6. So by Mendelian genetics, you will necessarily inherit 1 chromosome 6 from your mother, 1 chromosome 6 from your biological father. Therefore, each of your parents is at least a 50% match. And by Mendelian genetics, again, each of your siblings has a 25% chance of being a perfect 10 out of 10 match and a 50% match of being at least a 5 out of 10 half match. And so we think that our product may be better. And of course, we don't have the data for this. We are still completing the trial, but we think it may be better because we're using related donors with closer HLA matching, which may lead to better efficacy and persistence. So where is this all going? I've presented, I think, already a bit of the challenges, but I'd like to talk a bit more about some other challenges and how I think we may be able to solve them going forward. So I would say one of the biggest problems with virus-specific T-cell products they stand today is that they're just as susceptible to pharmacological immunosuppression as the patient's T-cells themselves. And as I mentioned, problem number 1 in how we currently treat opportunistic viral infections in immunocompromised patients is that lack of virus-specific immunity. So if we give a virus-specific T-cell product to somebody who remains on immunosuppression or needs an increase in their immunosuppression because of rejection or GVHD, glucocorticoids being a particularly big problem for us because they're often used to treat these patients, and these T cells will essentially disappear. And so for patients who can't stop immunosuppression, either because of their medical condition or because they have a solid organ transplant, and you can reduce immunosuppression, but you can never completely stop immunosuppression because you'll completely lose the organ, obviously this has an adverse effect on our product. And so one idea is to use gene editing to produce what are called armored T cells, essentially T cells that are resistant to pharmacological immunosuppression. And 3 groups have already published using CRISPR-Cas9 gene editing to remove the receptors for 3 commonly used immunosuppressants in the transplant setting: tacrolimus, the glucocorticoid receptor, which makes it excuse me, the cells resistant to all steroids. And at the bottom, I realize it's not in the title, but this group produced cells that were knocked out for CD52, which is important because it's the target of alemtuzumab or Campath, which is a very potent immunosuppressant used for rapid T cell depletion in transplant induction. And so if we were able to produce multiplex edited T cells that were resistant to tacrolimus, glucocorticoids, and alemtuzumab, well, that would leave our transplant colleagues with a significant armamentarium that they can still use to treat patients when needed, but while maintaining virus-specific T cells. Now, there's a lot of technical challenges to that, which I won't go into for the sake of time, but this is something that on the horizon is possible, and I think could really make these cells more effective in patients who must remain on immunosuppression. The other question is, could we use virus-specific T cells to treat other viral-associated cancers other than PTLD? So one idea, excuse me, I still have a post-viral cough myself, is to use virus-specific T cells perhaps to treat human papillomavirus-associated cancers. In fact, there's some plausibility for this because in a study of tumor-infiltrating lymphocytes coming from the Steve Rosenberg lab at the NIH, which is one of the pioneering labs in anti-cancer T cell therapy, what they found was that patients happened to respond to this therapy were the patients that had cells that happened to have cells that responded to HPV antigens. So there's quite a bit of biological plausibility for the idea that if you restored HPV immunity, you could perhaps treat refractory human papillomavirus associated cancers. In fact, a group from Children's National Medical Center in Washington, D.C. has already produced human papillomavirus specific T cells. This is also feasible to be produced. So I think this is an idea, and I can name a whole host of viral associated cancers where I think that virus specific T cells could be quite interesting as a treatment approach. And finally, could we use T cell therapies to treat non-viral infections? I realize that the title of my talk is about viruses, but nonetheless, both for mycobacterial and for fungal infections, there have been publications using different strategies to produce T cells, including a preclinical model of a CAR T cell targeting Aspergillus fumigatus, where the results were quite promising. Now, naturally, that needs to be proven in higher animal models and in humans. This was in mice, but nonetheless, it could be quite intriguing for patients suffering from other non-viral infections that we have a lot of challenges in treating in our immunosuppressed patients. But there's obviously some key unanswered questions. I think the main one is, what is the best donor? Who is the best donor? Is it a related donor? Is it an unrelated off-the-shelf product with certain amounts of HLA matching? Does this mean that we need to have large donor banks akin to blood banks or stem cell transplant donation, where we have already HLA type donors, where we could try to get the best HLA type from a donor who we already know to be suitable and seropositive? These are all strategies that are being explored. What is the optimal time point where we should treat patients with VSTs? I think that's also a key question. Right now, we've been using, and almost all of the studies that I've shown you today, use these cells to treat patients when they have resistant refractory disease, basically pre-selected to be the hardest, most challenging patients to treat. But would these therapies be more effective if we use them as prophylaxis of viral infections? Would they be more effective if we use them as consolidation once patients have responded to therapy, to give these T cells as an additional boost to prevent recurrence? I don't have the answer for that. These are things that are going to have to be established in clinical trials. Another key question, which really goes for our production methods, how do we improve virus-specific T cell efficacy and persistence? A lot of groups are working on different production methods, different cytokine mixes, pro-inflammatory cytokines, for example, to try to make a better, more effective, more persistent mix of cells that we infuse the patient. And of course, I think the question that's going to be the most important for actually making these commercially viable is, how do we make these therapies more accessible? Right now, to get onto one of these therapies, You need to have a GMP facility, as I mentioned. You need a good donor. You need a center that can actually perform this. But that's not going to be true for most of our immunocompromised patients. And so we really need to take a hard look at how we're going to be able to make these therapies more accessible over the long run as we make them more effective as well. So now that I've talked about virus-specific T cells, I'd like to take a few minutes before I take your questions, talk a bit about some gene therapy approaches to treating viral infections, which I think could be quite exciting as the next step down the road. So one gene therapy approach that could be quite interesting for antiviral treatment is what we call RNA interference, either using interfering RNAs or what are called antisense oligonucleotides. The idea being that these are nucleic acids that are complementary to the messenger RNA of the virus we want to treat, and that when they bind that messenger RNA, they essentially tag that RNA for destruction, meaning that proteins are not translated and virus is not produced. This sounds like science fiction, but there are actually 5 FDA-approved interfering RNA therapies currently on the market, all of which target liver diseases because the liver happens to be the easiest place to deliver to which we can deliver these therapies. Often what is said in gene therapy is that the adage is delivery, delivery, delivery. And if you can't get it to the tissue, you're not going to be able to use this treatment. So obviously the problem in viral infections, which are often disseminated in multiple tissues, and is going to be something we have to solve. But strikingly, the first antisense oligonucleotide therapy was actually approved all the way back in 1998 and happens to have been approved for, as I mentioned, our nemesis CMV. In fact, this was approved for treating CMV retinitis in patients with advanced AIDS, which is an opportunistic infection, which in the days before ART used to be relatively common in patients with very advanced AIDS and sight-threatening. And in fact, what they found on the left was with an independent observation. On the right, the Kaplan-Meier curve is observed by the patient's own ophthalmologist. This was placebo-controlled, and their primary outcome was time to first progression. And what you can see here is that an intraocular injection of this antisense oligonucleotide against CMV did significantly reduce time to progression. However, it should be mentioned that this study ran over the time when ART was being introduced, and they did not adjust these results for ART initiation, which is key because we know that immune reconstitution in HIV-associated opportunistic infections is the most important determinant of how these patients are going to do. This was removed from the market in 2002, not because it didn't work and not because of issues with safety, but simply because we got so good at treating HIV and we got better at treating CMV to the point that there really wasn't a market for this treatment anymore. Where there's a lot of interest in antiviral RNA interference therapies now is actually in hepatitis B. Again, as I mentioned, the easiest place to get these therapies is to the liver, and there is a large population, a worldwide population of patients with chronic hepatitis B, therefore a commercial interest in developing these therapies. And the idea essentially is to try to reduce production of hepatitis B surface antigen from integrated hepatitis B DNA in patients who are already virally suppressed on the established anti-hepatitis B antiviral therapies. They have been able to achieve some hepatitis B surface antigen suppression. It actually has been durable in the studies that have been published. I don't know how clinically relevant this is going to turn out to be as a treatment endpoint. A lot of it comes from chimpanzee studies, but nonetheless, it's proof of principle that we can use more modern RNA interference technologies to treat viral infections. And then finally, could we perhaps use an inhaled product, since the lungs are quite accessible, to prevent or treat respiratory virus infections? And so indeed, going on 15 years ago now, there's a small phase 1 trial where they looked at using RNA interference an RNA interference therapy to treat lung transplant patients with RSV, respiratory syncytial virus, which causes big problems in our lung transplant and stem cell transplant recipients. Unfortunately, the only therapy we have that we can use is ribavirin, and the efficacy is quite debatable, as there is a lack of proper placebo-controlled trials to evaluate ribavirin. And essentially, what they found on the left is that using an inhaled interfering RNA, they were able to decrease the RC viral loads, but also decreased the proportion of patients at day 30 and day 90. The white are the patients who received the therapy, the black are the patients who received placebo, who had at least a 20% decrease in their FEV1, so in their lung function. So they found not only that they were able to reduce viral load, but they were actually able to reduce the physiological consequences in these lung transplant recipients with their therapy. They then moved on to a larger phase 3 trial, where again, they found a significant reduction in the incidence of what's called the bronchiolitis obliterans syndrome, which is a complication post-RSV infection in lung transplant recipients. However, they did not go to market because their primary outcome happened to be reduction in bronchiolitis obliterans syndrome at day 180, and their p-value was just above it was just above 0.05. And for commercial reasons as well, the company decided not to proceed with development. But again, proof of principle that you can use inhaled RNA interference potentially to treat respiratory viruses in immunocompromised patients. Another interesting idea that came out during the pandemic, this group published in Nature Communications, the idea of using broad spectrum RNA interference to essentially be able to have a pan-coronavirus antiviral that could be used in the event of the next pandemic. So they use what's called CRISPR-Cas13 technology. It's a different kind of RNA interference, but it does target mRNA. This was all done in vitro. This was not done in vivo. So I think this would clearly have to be replicated in a more clinically applicable setting. But what they did find is that they were able to have broad spectrum inhibition of coronavirus, both endemic and SARS-CoV-2 replication when they introduced this CRISPR-Cas13 technology into an organoid culture. So this again is a bit of a proof of principle that you can use RNA interference also as broad spectrum and adaptable agents for pandemic preparedness in the future. So I think there's a lot of possibilities perhaps with RNA interference. Perhaps we could give prophylactic administrations during respiratory virus season. If we were able to pharmacologically if we were able to get suitable pharmacokinetics so that this could last a long time, perhaps we would be able to prevent patients from catching respiratory virus in the first place, since we know that vaccination against respiratory viruses in our immunocompromised patients is quite suboptimal. Perhaps we could have multi-virus targeted product for treatment of viral pneumonias, including viruses that don't have small molecule antiviral treatments this time. As I mentioned, some adaptable pandemic preparedness agents. Perhaps long-lasting prophylaxis of donor-derived infections, if we were able to give something, again, with suitable pharmacokinetics, especially if you could give it directly into the organ at the time of transplant, perhaps that would solve some of these issues of delivery. And as I mentioned, polyomaviruses and papillomaviruses, because of their relative simplicity, are very difficult to target with antiviral agents. Perhaps we could use interfering RNAs to target these difficult infections to treat. And so finally, before I take your questions, I realize it's going to sound a bit like science fiction, but could we perhaps use gene editing to completely eliminate latent viruses in the first place? I mentioned at the beginning of my presentation that our problems right now are twofold. One is the lack of virus-specific immunity, which I posit that we can use virus-specific T cells to solve that problem. But two is that we're unable to eliminate latent viruses, and so patients remain at risk of reactivation. And so one group, this is the Keith Jerome group at Fred Hutch, has been using gene editing using what are called meganucleases. So not CRISPR, but a bit of a similar concept to try to eliminate latent herpes simplex virus in vivo. So using mouse models. Now it's not perfect. In one lymph node, in one ganglion, they were able to eliminate HSV. In another ganglion of the mouse, they were not able to eliminate HSV. Obviously, this needs a lot of optimizations, but again, a bit of a proof of principle that we may be able to eliminate virus using integrated herpes viruses using using gene editing. And then another really exciting area is the idea of HIV cure. So this company, Excision Biotherapeutics, is working on, has 4 products that they'll publicly say are in the pipeline using CRISPR-Cas to try to eliminate integrated viral infections, HIV, HSV, hepatitis B virus, and JC virus, polyomavirus, which, as I mentioned before, causes PML. And so the idea, and so I'm showing the most advanced, which is the most advanced agent, which is EBT-101, which is to treat HIV, is to create 2 precise CRISPR edits that essentially cut out a large amount of the virus, essentially making it so that the virus can no longer enter the lytic phase and produce more copies of itself. So the idea is that you're not going to eliminate the entire virus, but you can eliminate enough of the essential genes for the virus so that you essentially produce a functional cure to HIV infection. And indeed, in humanized mouse models, they looked at performing a dual edit, first to remove the co-receptor CCR5, which most HIV requires to enter into a new CD4 T cell, and then a second CRISPR edit a week later to actually perform the excision to remove HIV. Now, what they found, I realize it's a bit of a busy slide, but I'd really like to draw your attention to the bottom right, is that when they suppressed virus using a combination of antiretroviral therapy followed by CRISPR against both CCR5 and HIV-1, then in 5 out of 10 mice in the first experiment and 6 out of 10 mice in the second experiment, they were able to successfully eliminate HIV, both when they looked for latent virus using highly sensitive PCR techniques, but also because they were able to interrupt antiretroviral therapy and the mice did not rebound virus at all. Now, of course, this is not perfect. First of all, it's humanized mice. We have to translate that into non-human primates and then to humans. I think there's a lot of work to be done there. And also, it's certainly not a 100% cure, but nonetheless, a big leap forward in the idea that perhaps we could achieve an HIV cure. In fact, they've been able to move forward based on these data. The FDA cleared them to move forward with phase 1 dose escalation studies. They have treated the first 3 patients who tolerated the therapy extremely well, and they're now moving on to their higher dose in another 3 patients. And they've received fast track designation from the FDA. So it is a possibility that we will see clinical trials sooner rather than later looking at CRISPR-based HIV cure. So that is incredibly exciting. And finally, could we apply these techniques perhaps to produce latent virus-free organ transplants? As I mentioned at the beginning, despite our current prophylaxis strategies, we know that when we transplant serologically mismatched organs into a naive recipient, those recipients don't do as well. So maybe we could remove the virus completely from the organs that or tissues that we're transplanting in order to produce better outcomes. And so indeed, there's a very active group in Toronto looking at ex vivo perfusion of organs. The idea being you can take out an organ and put them essentially on an external circulatory pump, almost like an ECMO for an organ, and keep that organ alive even for weeks while you treat that organ and you evaluate that organ if you're not sure about the organ suitability for transplantation. And so they actually took 6 lung pairs that were deemed not suitable for transplantation, put them onto this ex vivo lung perfusion machine that they have, and treated them with an antibody that depletes cells that are latently infected with CMV by targeting a latent CMV protein on the surface. Now, they only looked at this after 6 hours. So I think that it's a bit suboptimal to say that after 6 hours, we really have completely eliminated CMV, since we know that CMV reactivation happens months or even years later. But nonetheless, I think that this raises the idea that perhaps if we were able to take organs out in a serological mismatch situation, put them onto an ex vivo perfusion machine, and then be able to perform gene editing or some other technique in order to eliminate latent infection before we transplant the virus, we could essentially eliminate the problem of donor-recipient mismatches, which we are quite suboptimally treating at this time. And so, of course, this is quite aspirational. I think that this is many years down the road, but I just want to highlight a possibility of something we may be able to do in the future. And so, to conclude before I take your questions, I think it's clear that the cell and gene therapy era is here. We're seeing patients with CAR T now regularly, and we know that these are going to keep expanding over time. And this is going to be a really, really exciting area in the future. Virus-specific T cell therapies may be able to solve the problem of restoring antiviral immunity, although with the issues that I've mentioned that we've run into. RNA interference therapies may provide new prophylactic and therapeutic agents against drugs that don't have small molecule targets for a whole host of reasons, as we discussed. And finally, gene editing techniques could potentially cure latent infections, and maybe even we may even be able to produce virus-free organs in donor-recipient mismatch scenarios. So on that note, I'd like to thank my supervisors, of course, Dr. Jean-Sébastien Delisle from Maisonneuve Rosemont, where I did my master's, and now Dr. Marcus Pereira and Dr. Pavel Moransky from Columbia, and all of the people that I've been working on the trials that I mentioned before here at Columbia. And of course, thank Dawn for introducing me and for the mentorship and for giving me a bit of the kick in the behind that I needed to go down this road of academic medicine. So thank you for being here and for supporting me for many years. I think we have time for a few questions if there's some questions in the chat.
Well, that's great. Thank you very much, Lorne. Are there any questions for Lorne? I don't see any in the chat, and I don't see any hands. So no, Makit is just clapping. I agree. I'm giving you an iconic clap as well. While I allow people to digest that presentation and come up with some questions, I actually have a question as well, if you don't mind. Lorne, one of the issues with CAR T cell therapy directed to malignancies such as B-cell lymphoproliferative disorders is that it's associated with an increased risk for opportunistic viral infections. And the rationale mechanism somewhat is simplistic in the sense that they said, well, all your lymphocytes are sort of directed towards your malignancy, and so that leaves sort of like nothing to take care of the rest. I'm not sure it's that simple. There is the concept of lymphocyte homeostasis and filling in vacuums, but is there an opportunity for opportunistic viral infections in the use of the VSTs? And if so, are we just exchanging, 6 of one for half a dozen of the other?
I think that's a great question. So first, to answer the first question, we know that we see more opportunistic infections in general in the BCMA targeted cells for multiple myeloma than we do in the CD19 targeted cells for B-cell lymphomas. So there's something about targeting BCMA, and it perhaps is an off-target effect on T cells that has led to, and we see this also in bispecific T cell engager therapies against BCMA. So I think to answer your first question, one of the key principles is that it depends on the target. And the second thing that I think is important to mention is that CAR T therapies require some degree of induction chemotherapy, normally with fludarabine and cyclophosphamide, both of which are quite T cell immunosuppressant in themselves. Whereas with virus-specific T cell therapies, we have not given any conditioning chemotherapy before infusion. So perhaps that may also be a factor to consider. In the virus-specific T cell therapy trials that we've done so far, they've been incredibly well tolerated. We have not really seen further opportunistic infections, although of course it's very difficult to attribute to the product or to the patient's underlying immunosuppression, as these are very immunosuppressed patients. But notably, we have not seen any GVHD, which using partially matched HLA products we'd be quite worried about. It appears that memory cells produce quite a bit less GVHD than naive T cells. We've seen very little cytokine release syndrome. It has happened on occasion in patients with very severe, mostly with EBV-directed agents for patients with overwhelming lymphoma. But we've seen a lot less of the CAR T-related complications. Now, the question is that because our cells are better, or is that because our cells don't persist and don't hang around for very long, which obviously would be a downside rather than an upside, despite the fact that they're well tolerated.
Yeah, so while I allow people to think about that question, can I just add on to that last part? So can you remind me, maybe you said it, how long do these cells last? And is this something that you anticipate may require repeated infusions, given that some of these,
Yes.
some of these immunocompromised states can persist, if not, lifelong because of the underlying condition?
So the short answer is we don't know. The slightly longer answer is we believe in our study, and we'll of course be looking at patient samples quite closely, that our T cells persist for about 14 to 21 days in general. Again, because as particularly in solid organ transplant patients, we're dealing with patients who don't have an empty marrow, so don't have any engraftment of these T cells, unlike CAR T cells that are able to have some engraftment and thus persist longer. In our trial, we're able to give up to 3 doses, 28 days apart. The AlloVir trials were giving cells weekly or biweekly. So they had a very aggressive dosing regimen. Again, likely because of lack of persistence. They will not persist for the lifetime of the patient. That is for sure. And again, that is, I think, one of the limitations of these therapies at this time. I actually got a private message from Dr. Tsukis. If you don't mind, I'll read it out and maybe answer it, because I don't think everyone else can see it. So is the concept in use of virus-specific T-cell therapies to achieve sterilizing immunity? If not, what is the clinical aim? And I think that's a great question, because I think that the idea is essentially, as we're using them right now, to try to bridge patients through their period of maximal immunosuppression until they reconstitute their own T-cell immunity, which obviously is much more doable in stem cell transplant than in solid organ transplant, where patients each remain on immunosuppression for the rest of their lives. And so I think that is a great question. So the clinical aim is really for patients with these resistant refractory infections to try to get them through those infections, to try to get them to a point where their own endogenous immunity can take over and hopefully clear the infection. However, that's obviously not a completely optimal approach. And so we need to refine this. So I think that's a great question. Thank you for it.
I see Makeda has her hand up.
Yeah, thanks. Thanks, Lorne. I may have missed it, but for these VSTs, you mentioned that it would be for serologically mismatched donor and recipient, but have they been tried for recipients that are positive and donor positive, or is it only for the negative recipients?
So we can use them for anybody with a resistant refractory infection. They don't need to be serologically mismatched. For prophylaxis, I think we would use them for the highest risk patients, which are the serologically mismatches. But certainly patients with patients who are not mismatched but have integrated virus are at risk of reactivation. In fact, the serological mismatch is often reversed in stem cell transplant recipients, where we see is people who get a donor, cells from a naive donor in a recipient who has the latent virus are the ones who tend to reactivate and have the highest risk. So absolutely, we can use it in serologically positive donor recipients.
And is there any sense of the potential impact of the VSTs on the native T cells and B cells of the recipient against that same virus?
So we don't know. We really don't. I think that's a great question we need to answer.
We have a quick comment from Sasha. What an amazing age we live in. I agree. And Dr. Doss has a question in the chat. I invite you, Lorne, to read it and to feel free to answer it.
About post-acute SARS-CoV-2, I believe. So I think that it's difficult. It's a difficult clinical landscape in terms of, I think it's a difficult entity to define, and proven post-acute SARS-CoV-2, I think, is going to be difficult to define and thus difficult to come up with a treatment for. There are some anti-SARS-CoV-2 cells that have been developed and tried to treat patients with persistent COVID or severe COVID in cases of T-cell immunocompromise. So absolutely, COVID could potentially be targeted with cells, and there are a couple of groups and case reports that have targeted COVID using in solid organ transplant recipients with resistant refractory disease.
And just with the last few minutes left, Lorne, I see Safa has a question, and then after that we can wrap up.
Okay, great.
Thanks, Lorne, for such a great talk. It's a quick question. I was just wondering, you
Sure.
spoke about virus pathogen. I was just wondering if there's similar studies that are done with those technologies for like non-viral pathogens such as histoplasmosis, for example, or tuberculosis.
So there was a study. I'm happy to send you the references that looked at mycobacteria. So it looked at TB. They expanded cells against TB, M. abscessus, and M. avium. I can certainly send you that reference. And then there are two groups that have looked at fungal agents. So one expanded cells against Rhizopus oryzae using using peptide mixes and a rapid expansion protocol. And then there's an aspergillus targeted CAR T therapy that has shown promise in mouse models of aspergillosis. I'm not aware of anything against histoplasmosis, and I'm not aware of anything against parasitic infections either. But perhaps that would be an area to expand this into.
Thanks so much.
Well, with that said, I thank you, Lorne, for an excellent talk that reminds us dealing with infections that we're not just targeting pathogens anymore. That the field of infectious diseases is an evolving paradigm where we're also now manipulating the immune system to help succeed in combating that infection. And your talk was an elegant demonstration of what I hope the near future will hold for all of us. So thank you very much for this wonderful talk. Thank you, everyone, for your attendance, and see you all soon.
Thanks so much.